Welcome, everyone. I'm Denny Brennan with the Massachusetts Health Data Consortium, and it's my great pleasure to present to you today's webinar, COVID-19, a Catalyst for Change, and how it could transform the national health data ecosystem and the health of all American communities. Today, we are very excited to have JT Lane with ASTHO discussing with us how COVID-19 is this catalyst for change and how it can transform the national data system and health data system for the benefit of all Americans. Before I introduce JT and get started, let me share with you a few details about today's presentation. Today's webinar will last approximately 90 minutes. We've allocated roughly 20 to 30 minutes of that time for your questions, and the remainder for JT's presentation. Before I introduce JT, let me also provide you some additional information. You will be in listen-only mode, and as such, you will be putting your questions in the question panel that should be on your screen. We will review your questions and we will ask them during several breaks we have during the presentation and one break at the end of the presentation. Our webinar is being recorded and will be available on our website in a few days. And we've also attached the presentation handout to the GoToWebinar handouts page if you're inclined to download that and share it with your colleagues. We encourage everyone to tweet during the webinar. As you can see on your screen, we have our Twitter hashtags and handles for your use. We will also be tweeting ourselves and sharing the findings and the information we learned from JT over the course of the presentation. When you exit the webinar, you will be provided a very brief survey, and we encourage you to take a few seconds to answer the few survey questions that we're posing to you at the end of today's discussion. I also want to remind you that next Thursday, August 18th, we will be presenting Dr. John Toros and his colleagues from the Beth Israel Deaconess Medical Center and their digital psychiatry department talking with us about behavioral health apps, how they're evaluated, and how the mHealth Index and navigation database can help consumers make the best possible decisions. We have a lot to cover today, and I want to first tell you a little bit about JT Lane. JT serves as the Senior Vice President for Population Health and Innovation at the Association of State and Territorial Health Officials. This organization represents the public health agencies of the U.S. territories, the District of Columbia, and has well more than 100,000 public health professionals who work for these agencies, serving the needs of Americans who use the public health enterprise across the country. In his role, JT leads a team and a portfolio of programs that are designed to focus on state and territorial partnerships. These goals include state and territorial public health data capacity building, building health data management infrastructure, rural health, primary care and public health system integration, and a number of critical and essential initiatives to improving the health of all Americans. He also facilitates cross-cutting innovation planning and strategies that are inclusive of all public health plan program areas, including health equity and the social determinants of health. JT brings nearly 20 years of population health and human services experience and has supported a variety of local, national, and global organizations in advancing population, health care, and human services. And with that, I'd like to welcome JT. Welcome, JT, to MHDC and our webinar today.
Thank you so much, Denny. I really appreciate the invitation to share with all of you today. where we are as a community in public health and how COVID has obviously changed our trajectory for the future and what we're thinking in terms of modernization and how we can create a better future for the country, better engagement with healthcare providers and plans and health information exchanges and all sorts of entities. I do want to offer some special thanks both to you and Katie and Betsy and your whole team at your organization for their support in preparation for today's discussion. Y'all have been great. I'm really pleased to start this conversation. I hope it's going to be one of many about how COVID over the last 28 to 29 months, how it's impacted state public health in so many American households, providers, and other systems, and so many others. It's been truly unprecedented, as we all know. But I'd also like to have a conversation about what our experience was with COVID, how that can catalyze transformation within our national health data ecosystem, and which, for the purposes of this, I'm including that as healthcare providers, health plans, public health agencies, human service programs, social determinants programs such as education and housing, and community-based organizations. So, but first, to set the stage, I think as we transition to slide 8, I'd like to give a quick background about ASTHO, what state and territorial leaders and agencies have faced, and where we're going. So, as the slide shows, ASTHO, we were incorporated officially in 1942, but actually have history that comes back into the late 1800s. When the Mississippi River Valley jurisdictions were looking at forming a national organization to represent public health due to specific challenges that we're facing there. But ASTHO, since its inception, is the primary representative in policy and advocacy within to Congress and federal policymakers and other groups. We represent the 59 chief health officials of the 50 states, DC, the 5 U.S. territories, and 3 freely associated states. So our members, such as Palau in the Western Pacific, which is just 1 hour flight from the Philippines, come from the far Pacific, as well as the U.S. Virgin Islands in the Atlantic. And our organization provides leadership, organizational support to state health officials and their leadership teams, capacity building for their own capabilities and services within the agency, and then government affairs and policy advocacy on behalf of our members. What sort of like the big public health funding needs are, as well as significant public health populational challenges facing the country, such as opioids, for example. We have programs and policy areas spanning the range of, I think, the traditional public health disciplines from health security, behavioral health, maternal and child health, and chronic disease. But for my portfolio as well at ASTHO, we have an entire set of programs that are around building out and transforming the health system. So we have engagements and projects focused on Medicaid and value-based payment and health plan engagement. How do we promote partnerships between public sector programs, but then also partnerships with large systems, such as, how do we examine sustainability for rural hospital systems, for example. We have an entire research portfolio, and then we have our public health data modernization portfolio, which is doing a wide range of things. So going forward, in the next slide, I want to start to give you a sense of the, next set of slides, give you a sense of the workforce governance and financial dynamics our member agencies face. And this is for a specific reason for our topic today. So as you can see here, our member agencies employ more than 100,000 professionals that take on a wide variety of roles and disciplines within these agencies. And this diversity of professions naturally is, systems are perfectly engineered to produce these sorts of operational parameters and outcomes that you see here. They also produce, they're backed up by a huge diversity of federal funding sources. More than 7 federal agencies fund state health department work. And I think that's really important to know, and because it can lead to some complexity. I myself am a former health official. I was the state health official for Louisiana for 4.5 years, and certainly it was an education for me in just how complex our work was in the field. And then in addition to the federal funding, there's a wide array of local and state sources that also fund operations. So I think this is, a critical point for us to remember as we're going through the rest of the presentation, and also as we talk about the future in terms of challenges that we might face in achieving something greater and more meaningful as we talk about health system modernization, specifically to data modernization in our systems, and how we leverage them also to impact health equity. So let's talk more about workforce on the next slide. Health departments employ, as I mentioned a minute ago, a wide array of professionals, and many are required and needed by these federal programs to administer at the state and local level. And all of these individuals have played a critical role in the response. So, you can imagine that many of these individuals have experienced obviously a massive increase in the work they've been doing for the last 28 months. Their roles have changed at varying points during the response. Like, so for instance, in the first 6 months of the response, before Congress had appropriated a lot of money to beef up the capacity of health departments, we were switching from contact tracing, for example. A lot of health departments were moving contact tracers and disease investigators from programs like HIV and STDs, tuberculosis, into doing the same work for COVID-19 initially. But here you see the workforce statistics, latest statistics we have for health agencies. So as we move into slide 11, I want to talk about governance and the operational models of public health and how they vary as much as funding and workforce. So each state governs public health in these 4 ways indicated here on this map. And this authority is delegated to the states by the federal government, which is rooted in the Constitution as well. And we have these, centralized, decentralized, mixed, and shared models. So centralized models are largely where the state is running both, not only its state agency, but also all local health departments. They are one integrated system across an entire state jurisdiction. Decentralized states, or largely decentralized states, operate in a different model in which the state health agency is there to receive federal funding, but the counties or large cities have the statutory authority to operate those programs at the local level, independent of the state apparatus. So and that varies simply, but it's based on what's in statute for that state. And then we have a few states where the management and operations are somewhat mixed, where you have some parts of the state are managed by the state government and some parts are managed locally, and a lot of times that's due to local capacity and local decision making. And then we have shared, which is a more of a negotiated agreement on how the state and local governments take on the burden of services, disease monitoring, et cetera. And so this is really, important. And I think that I want to take a moment to reflect on, when I say these are important, in the context of the COVID response, I cannot underscore that enough. You can imagine if you were trying to run a private sector organization like this, how much of a management nightmare that might be. And this contributed in many ways when you have states of varying management models, varying degrees of funding, the same silos of funding, their capabilities in different, in different levels of state investment. So their capabilities of reporting COVID data, for example, quickly to CDC or HHS can vary somewhat because you have all of these factors that play out differently in each state. And I can remember, a period of time about 15 years ago when someone told me that, if you've seen one health department, you've seen one health department, and I didn't quite get it at the time. And so I certainly understand it after being a health official and continuing my engagement work with public health programs and agencies as both a consultant in the private sector and at my role at ASTHO. So as we move into the next slide, we know that public health, as I was mentioning for the response, faced a lot of scrutiny. And as I was saying, all of these factors are important because they contributed to some of the weaknesses in the response, both at the local, state, and national level. And so we went through this phase, obviously, in the public discussion around is public health at the breaking point, and we received, investments to shore up health department capacity at the local and state level, and we have been trying to simultaneously for the last 2 years respond to a pandemic for the first time in modern history, while also trying to shore up capacity of the system at the same time. So that also means that we only got a fraction of the work done that we needed done during the response, and we have a good 5 to 10 years of work ahead of us to truly modernize the public health system of the country. So despite that, despite the questioning of that, and despite the uncertainty around this, I want to go into slide 13 to talk about some silver linings. So despite the weaknesses and despite scrutiny and harassment and exhaustion of our members and their teams, there were definitely examples in many states where public health leadership was sort of exalted and appreciated. On the left, you'll see, Dr. Nirav Shah, who is the state health official of Maine, and he's our current president. And his leadership and messaging throughout the response actually got a movement going across the state of "In Shah We Trust." And so you'll see in that picture at that bookstore that people made banners and sort of exalted his leadership, him and his decision making as well. And we also saw a whole slew of other officials across many jurisdictions rising to the challenge. And then, in the far right in Chicago, Dr. Ezike, who's the former official for Illinois, she recently left the department, but threw out the first pitch at one of the Cubs' first games. And so, we've had, glimpses of where we've seen public health supported in many places across the country. And so as we move into slide 14, I want to talk about some polling data. So still, despite these weaknesses, we worked with Harvard to, I would say over the last year and a half, to start monitoring trust in public health across the country. And I'm really pleased to say that after a very robust development of and methodology of the surveying and our analysis, that public health trust has remained fairly high, and depending upon obviously depending upon the jurisdiction locally or the state level, but nationally. more than 70% believe public health activities are important to the health of the U.S. More than 70% still have positive feelings about public health institutions at all levels. And I think, as we've seen in some of the media coverage, which is the tendency to focus on the bottom two boxes of no trust or not very much trust, we have seen consistently, most recently this year, that that the public, 72% of the public is still saying they trust their state health department to provide accurate information around the coronavirus outbreak. So this, to me, is, these are positive developments still for us, going as we head into this period of reflection and plotting a course forward. So moving on to the next slide. So, we are at this truly unprecedented historic moment to completely transform what we do in public health in America. Not just how we do the work that we are legally required to do or required by federal funding sources, but also how we go about engaging our stakeholders. Because from my perspective, and I would say the first big group would be healthcare providers and major health systems. If we do not constructively engage that community and we don't have their data, we don't have a response. We don't have the data we need. And so better understanding the burden of public health reporting and data collection on the provider community is something I think that we are more interested in learning and understanding better, so that we can act on it and provide guidance to our members, so they can be more successful with that in their jurisdictions. So in the next slide, where are we going after this? And I want to jump to the next slide to talk about a recent activity we did. So and actually, as of the other day, there's a fifth report. So we haven't had a chance to analyze the findings in it, but we all know that when we face crises like this of national magnitude, there's always a ton of analysis and examination of what went wrong initially, what went right, what could be improved upon, and where do we need to go. And so we actually did an analysis at ASTHO of these 4 reports from the Bipartisan Policy Center, Deloitte, its Public Sector Government Insights Group, the National Academy of Medicine, and the National Network for Public Health Institutes, as well as the Texas Public Health Institute. And the next slide, we sort of dive into, after we sort of analyze this, and I've bolded data systems and equity because that's what, that's the meat of what we're talking about today. These are some of the things that we found consistent across all of the reports. Data systems, everyone, there's, I think, without, polling the entire country, I think there's, unanimous belief that we've got to focus on modernizing our data systems. And we know that our systems issues are not technology problems, meaning that the technology to fix a lot of what broke down exists today and is leveraged really well in the private sector. A lot of what we're going to need to be doing going forward is, how do we manage change? What's the impact on the way that we do our work from a surveillance perspective, and the impact of pivoting to more of an enterprise level approach and strategy when it comes to developing new data systems or an enterprise architecture that's modular in nature. And then as we think about this, and if we think, we have a tremendous opportunity with the investment that's been made in many of our data systems and data modernization overall, we have a chance to ensure we're doing that through an equity lens. Are we capturing all of the data that we need for equity? And I would point to an early example in the response after the vaccination campaign began. Only 50% of the states were collecting race and ethnicity data for vaccines and were able to report that to the Fed. So we never had full race and ethnicity data available to us at the beginning. Today, I think we're sitting at about 90% of jurisdictions reporting race and ethnicity data too, but there's still micro issues that we need to work through on that. So with that, I'd like to just pause real quick. I know that is a lot. I think this is important information for all of us to keep in mind as we go into the next parts of our talk today. But Denise, if it's okay, I'd just like to maybe pause and see if there's any questions that people might have that I can answer at this moment.
JT, we have quite a few questions. I'm going to try to parse them so we can do some now and do some later.
Great.
One of the first questions we have is how much public health data comes from traditional provider reporting and how much from other sources? Are there mechanisms for collection that don't rely on primary care?
When it comes to COVID, so there's laboratory reporting for positive tests. So this is coming from state public health labs as well as private sector labs. There's case reporting from surveillance systems that health providers, so it's primary care and major hospital systems that provide a bulk of that case data. We have, ironically, part of the modernization initiative and part of surveillance is looking at the death data. So what are we collecting from COVID deaths from medical examiners that's really important to inform any trends that we're seeing that we may have missed through initial, positive tests and case reporting from them. So a lot of state medical examiners are a component of that. Funeral directors all across the country are the ones that certify death records once they're complete as well. So there are other constituencies too that are involved in that entire ecosystem for these areas specifically.
Terrific, thank you. Back on slide 11, we don't have to go back there, but in slide 11, you showed a map of the United States, the territories. And, one of the questions that comes up is, with all those different governance models in place across the country, mixed, shared, state-based, et cetera, in your experience, do you see any of these models working better or worse than the others? Are certain governance structures more responsive, more resilient, more comprehensive in their data collection than others? What are your thoughts about that?
That's a very, very good question, a tough one, because there is, the statutes of states or local ordinances really dictate those relationships, and there are so many nuances. It's even we constantly have a discussion, and we are right now actually around the governance categories and the methods and the different factors we include. And some might assume that automatically it's a legal question only, but there's also things like funding and the political structure that dictates the behavior of those agencies. So the other question here too is, where does public health sit at the state level? Is it a cabinet level agency that reports to the governor, or is it part of a mega agency that reports to a secretary, executive secretary, or commissioner that reports to the governor? And so there are lots of layers of that onion to peel back. So I haven't put my hands on a report that says definitively this is the this one way or the other is the right way, because you have states like Rhode Island, right? small geographically, lower population. You've got states that like Texas, Florida, and California that have varying degrees of relationships with their locals. So California is highly decentralized, where every county literally takes the lead on a lot of public health decision making in concert with the state. But that works for California, which we all know California is always an outlier when you're, have an economy larger than most countries on the planet. So, it's a difficult question. I think initially it was meant to the diversity was meant to allow states to have flexibility to design the system based on their immediate needs. Where I think we are right now is that it's time to take a real hard look at what our needs are. They're not the same as they were when our systems were first built. And so what is it that we need today? And there's often a talk about state flexibility, states that want flexibility on certain issues with the federal government. Well, they've traditionally fallen into a few buckets, but are those going into, after this response, are the buckets of flexibility the same? Do we need, yes, we still philosophically need flexibility, but do we need it in the same areas? We don't know that yet. And I would just add one thing that, from a management standpoint, and I am biased on this, so I would say as a health official that in Louisiana, public health is highly centralized. Louisiana is a state that often seeks state-based solutions at the legislature or at the governor. And so culturally, that is how we're sort of set up. And so public health is highly centralized. So every public health department in all 64 parishes, all of the nurses and outreach workers and disease investigators, all were part of my budget and team across the country, across the state. So when you centralize it, I just mean from a centralizing perspective, it's easier to manage that and the resources that way and get feedback locally. But when there's more of a political division, that's where you have to engage a little bit differently. So that takes more time. So I would just say that those are some things that I think about. I don't have a, I think that we need to revisit how we do it, but there's not enough evidence out there that says that one way or another works best. But there are ramifications for being so diverse and having so many nuances too.
Terrific. I'm going to ask you one more question, and then we'll allow you to move forward with your presentation. What efforts are you seeing to address health equity issues when dealing with public health data? Are they focused mainly on race and gender, or are other marginalized populations specifically considered?
Yes, definitely race and gender. We also look at, just because in our work, we tend to look at urban and rural health as well. That's a major component of a lot of health access work we do around primary care and behavioral health, and how telehealth and community health workers are deployed to help sort of close some of those gaps. So I think that, whether or not you live in a rural community or urban area or other disparities that we look for. And we're examining a few others, but I would say that generally speaking, I think that you can go just about anywhere across the country, and those are the major factors that we're looking at through an equity lens. But there are more. I would add LGBTQ plus community. We have done some work on analyzing access for the ID and DD community and Medicaid, and what COVID did to access to services for that population as well. There's some specialty work we've done, but those are some other areas that we've examined and are still examining right now, especially I would say in the LGBTQ plus community, especially gay men, bi men, and other men who have sex with men for monkeypox as well is something where equity has emerged.
Well, thank you very much for those answers to those questions. We have a number more, but we also know we have 2 more breaks during the course of our discussion to ask them. So I'm going to turn it back over to you and let you continue your presentation.
Great. So let's just jump in to going into slide 20. So we want to now talk about, so how is what we've learned, how can COVID stimulate data modernization as it's envisioned now for public health, but also how can it encourage, really push us to think bigger for the future? Like really, where do we need to be going after we accomplish public health system modernization itself? What's next? And I really think that's important because I think that even as we're modernizing public health systems, we have to keep health equity in mind. We're making lots of investments in systems, and we're for instance, I mentioned the immunization systems and data gaps there. Closing those gaps while we're spending time and resources on redesigning systems, we should be, while we're doing that, we should be closing whatever other, identifying whatever other data we need, and making sure that that's part of the solution today. So, COVID obviously, exposed, tons of weaknesses in our infrastructure, as I've alluded to. Public health has long had aging systems and an inability to handle high data volume, low interoperability, and lack of common data standards. This is, really about, there are states that may acquire a platform from, a Salesforce or other types of other companies that are developing tools for health departments. And then there are states that have homegrown systems designed custom for their needs. Well, this does not help when we're trying to report data to the CDC for national decision making because of all of the variations in these types of solutions. And there continue to be ongoing policy and legal concerns. And I think that from a national perspective, the silos do not just exist at the local and state level that are driven by funding, of course, but the CDC itself has over 100 different surveillance systems it maintains for a variety of diseases, conditions, and uses. So this again, I want to reinforce the point that this again creates sort of a recipe for inefficiency. I think that we've seen play out in various ways during the pandemic. So in the next slide, I'd like to just talk a little bit about informatics and the workforce and some of the challenges. So I showed everyone the workforce data at the beginning of the presentation, and I wanted to point out that, like under laboratory and data professionals, we've got significant number of lab workers and significant number of epidemiologists in states, statisticians in states. But informatics, informatics is a profession that is, relative to other core public health disciplines, it's fairly new. And, in the informaticist's job is to lead this sort of cohesive, comprehensive, enterprise-wide strategy and system development so that there is no fragmentation and there is no, we were looking for creative ways to merge funding together to create a more common solution. And there's only 734 of them, and these are not necessarily the CIO of an organization, but they're maybe scattered throughout agencies. And so increasing the pipeline for informatics and informatics leaders to be able to work in health departments, to lead, work with the state epidemiologist and work with the state lab director and the state vital records registrar for birth and death data, and other program directors, and then engage healthcare systems and payers, state Medicaid programs in ways that help us build these systems that are more interoperable and more easily share data together to reduce the burden of reporting are really important. And that's really what the purpose of an informatics expert is, an informatics leader is in the health department. And so, again, the fundings that created those data silos, the informatics person is the leader that can help design solutions that improve upon that. The maintenance of these systems that we have today is very inefficient. And, and then of course, the bigger challenge we have, which I think is a challenge in many areas of government, is that technology leaders are not necessarily drawn to public health or other government jobs. There's heavy competition. As I said, we don't have enough in the pipeline. And so it's hard necessarily for state or local governments to compete with very large, global corporations when it comes to technology, data science, and development of solutions. So, so these are, in part of the data modernization initiative is to help better prepare a workforce for the future and think a little bit more innovatively about how we do that and work within the confines of state civil service systems. So what are new ways that we can do it? Who are new partners from the private sector we can bring in to overcome this? So I want to highlight just in one really quickly in greater detail on the next two slides what I mean by the data funding silos specifically. So here is a chart and followed by another one where these are the programs that are funded separately by the federal government at the state level that are related to data collection. So there are separate funding silos for data for injury, chronic disease, behavioral risk factors, environmental epidemiology, and the next slide, a few others where we have, morbidity data both broadly for the population and for mothers, adolescent behavior, neonatal abstinence syndrome, cancer incidence. All of these, this is specific to data. All of these either populations or conditions have their own set of funding. And I point this out to say that, we often say we don't have enough money. And I think that that's the case. But we also know that the money we do get, if it's distributed this way and spent in all of these programmatic silos, we're definitely not getting what we what we should be getting in terms of value from it. And so exploring other ways to overcome that challenge is really important. And as Congress continues to make decisions about funding DMI further, I think we need to keep that in mind. And we need to really think hard and fast about, from a programmatic perspective, if I'm a maternal and child health director, for example, I would benefit from having a chief informatics officer handle the maintenance and development of my system and look more at my role as maybe the owner of the data, not necessarily the owner of the system. And if we pull these resources more effectively, we could make more progress a little bit more quickly than what we've been accustomed to over the last 4 or 5 decades. So in the next slide, I want to start talking about though what exactly we're doing as a country and what's being led out of the CDC. So the data modernization initiative, which is currently funded for the next 5 years through a variety of different mechanisms, is focusing on these 5 strategies. So how do we govern data management? How do we erect the right policies to protect patient data going forward in a more unified fashion? How do we foster public-private partnerships to keep fueling innovation, to stay ahead of the curve? So I like to think about DMI as not just a one bam thank you sir and ma'am about that we're done. Like, we're not going to be done with this in 5 years. We all know, I mean, anybody with a a smartphone knows technology doesn't stop changing. So we need to find ways to develop those right partnerships with the private sector to make sure we're staying and keeping up and staying ahead of the curve too. I mentioned workforce. We need a modern workforce to tackle these challenges. And I would say that informatics is not, the state or agency IT team. These are a very skilled workforce that both understand system design, they understand solutions, digital innovation, and change management, which is another big component. I mentioned that technology is not the major problem with modernization. The technology is there. It's really about change management and how we change our way of thinking and operating based on the last 40 to 50 years. Interoperability is going to continue to be a major issue. There's been a lot of progress made on interoperability between immunization systems, especially, and healthcare providers, where their EHRs are feeding data directly. Lots of progress made in health system feeds as well, but we still have a good ways to go in making that a true reality, and we want to get to 100%, I think, nationwide, and interoperability of data reporting in our systems across the country. But also examine, where we need to be interoperable within ourselves internally to create more efficiency and lower the burden on both the public and private sector when it comes to data collection, reporting, and analysis for action. Because at the end of the day, this data that we're getting, the faster we can get it, the cleaner we can get it, and the more rapid the analytics are done, the faster we can act as a public health and healthcare community with civic and political leaders to protect the public. And then the last one is the infrastructure for this. And state Medicaid programs experienced this a little bit too over the last decade when it came to modernizing their systems and breaking down their programmatic function silos. But how do we actually implement an enterprise approach that supports and guarantees and builds trust with public health program experts to make sure that we all have the data we need when we need it, and then an enterprise approach that is inclusive of meeting all of those different constituencies' needs. And then I would say that as we're building out an enterprise approach, whether it's a common enterprise architecture or some other initiative, I've mentioned public health programs, but I also want to say that the other key input and engagement here is with healthcare and health plans. There's a ton of opportunity there to better understand the challenges that healthcare providers face when we're in the midst of a pandemic or any other infectious disease or other public health issue we're trying to track, is to get their input as well as to what's most essential to the functions of this modern world we're trying to get to. So this is really important from a strategy perspective. So what have we been doing, I guess, and what have we been funded for? Let me say that in the next slide. I wanted to give everyone a quick picture of where we are today, as of today. So throughout the pandemic, so I would say that first off, in 2019, the public health community released an analysis of what needed to be done that was encapsulated in what I just shared in terms of those 5 strategies to achieve modernization. The initial ask was for $1 billion over 10 years. So that's $1 billion over 10 years. We have received $1.2 billion in 2. And we're going to continue to advocate for it, which I'll go into in the next slide. But this slide shows that we've started out with the $50 million investment right before the pandemic hit, right before the lockdown. Then we've been consistently getting more and more investments for data modernization going forward. Now, that $1.2 billion seems like a lot of money, and it is. Well, we wouldn't all do for that much, but I would say about 500 million of that is helping the CDC modernize its own systems and break down its own silos. Around 250 million of that is going to the new Center for Outbreak Analytics, so that we are creating, in a way, a sort of a national weather service-like model for potential infectious threats nationwide. And so, that's really important because we want to be able to get ahead of this and be able to determine what's the genetic variation across the globe, what kind of development or evolution are infectious agents having, and be able to predict when maybe the next pandemic is likely to occur. And so, and then a good bit of the money is going to the states to modernize their systems as well. And so this is definitely a work in progress, as I'll show you in the next slide, that really hits home what we need to do. So the Healthcare Information and Management Systems Society, HIMSS, did an analysis of what's going to be needed over the next 10 years to really get to the place we want to go. And 10 years, I think, is a very accurate expectation for success. When we get to the end of the road of what the first phase of modernization looks like, knowing that it's an ongoing progress, it's going to cost us $37 billion to truly modernize the nation's infrastructure when it comes to data. And that's $26 billion for state and local health departments, but another $11 billion to create the frameworks for interoperability, meaningful use, and sustainability, to create incentives for healthcare providers and vendors and others to help adapt to this changing landscape and make sure that the solutions and products we're bringing to the market are responsive to exactly what public health needs, to have the data it needs for public health action to hand over to county executives, governors, and the president at the end of the day. So with that, I was planning to take a break here for questions, but Denny, I'm looking at time, and I thought I might just continue on, and then we could close out with a good chunk for questions, or your preference.
Why don't we do that, JT? That makes sense. It's now about 8 minutes before the top of the hour. If we could sort of set aside, maybe 20 minutes or so for the remaining slides, and then we'll have an open-ended set of Q&A at the end. How about that?
Great. Yeah, I'll try to get through it.
We know you will. We're confident. You've been moving at a good clip already, so we're appreciative of that.
So what's possible? And this is where this is sort of the punchline of the presentation that I want us to get to. We're at this juncture where we have all this investment, and I mentioned earlier there's an opportunity to as well while we're doing this, that we can walk and chew gum, and as it relates to health equity. And so I wanted to talk about this, and this is more for our thinking, because I think there's there's definitely a lot of development and additional analysis needs to go into this. But if we're really going to solve health equity, if we're going to create a more equitable and just society, the best place for us all to start as state leaders and as providers or community-based organizations that engage local or state government in many different ways across the country, we need to be thinking, I think, a little bit more broadly for the future. So in the next slide, I want to just, again, reflect on, here, this is what current data modernization is sort of focused on. It's the federal changes and the state and local investments and changes in their systems, and the healthcare facilities and providers that are impacted by that around laboratory reporting, case reporting, birth and death data systems, as well as immunization information systems. But in the next slide, I want to start talking about the COVID investments and COVID impact around data modernization. So, we knew before COVID, the country was never where it needed to be, and many American families living in poverty, racial and ethnic communities, and other marginalized groups experienced and continue to experience profound inequity in health and well-being. And in many ways, Congress's response to getting resources out to the country, as we saw historically, the most significant investment in American families and American communities and local governments to handle the burden of the pandemic. If you map social determinants to all of the programs we have online today, there's a lot that's there. Nutrition, childcare, education, tenant assistance, both for rent and home energy. It's all there. We have the framework. It's not perfect and it's not enough, but starting there, I think we can make progress, because the data contained in that ecosystem of programs is significant as well, and there's a lot to explore. So as we move into the next slide, I want to just show that, like, again, amongst as we're thinking about social determinants and we look at the federal programs, here's just a snippet from a couple of studies that, nationwide, amongst SNAP households, around 80% are also on Medicaid. Among TANF recipients, 90% are enrolled in Medicaid, 80% also receive SNAP, and 10% are receiving housing benefits. And I say that because there's clear, that many people and families that are in one of these programs are potentially receiving benefits from at least one, likely two, and could be more. And that creates an opportunity for us to think about, as we think about these programs, meant to address social determinants, what's our end game here in terms of that data ecosystem? We have an opportunity to build, I think, a mindset, an ecosystem that reflects local innovations. It's not to say that there are examples locally of where public health and let's say SNAP programs and Medicaid are collaborating. We've certainly built eligibility for Medicaid, WIC and TANF and SNAP together already, and we've demonstrated that eligibility can be done collectively. But there's also data, SNAP captures data on housing and security components for families, and I think about how meaningful it could be, since 80% of SNAP households are on Medicaid, and Medicaid programs want to take on a social determinant initiative, which we've seen many take on housing or transportation, especially. What opportunities are there, and what would we do with that housing, that food insecurity data from a health plan or health system perspective? Health systems, hospital systems are doing their community benefit planning. How beneficial would it be for them to have access to that data in aggregate at the community level or the census level or within their catchment area to inform their work going forward? So this is this is to me a reason why we should be examining this a bit further. And there's some work that we've done in this area a little bit already that's demonstrated different components to this. So in the next slide, I just wanted to graphically represent what I'm meaning. So we took like sort of the current nexus of groups that are involved in today's modernization efforts. But as we think about the future, education, education and Medicaid, through the IDEA and IEPs that and individual, plans for children with special health care needs, and the school system already share data, and many do it, have really been innovative at the local level. Housing programs, nutrition. This needs to start become part of as we think about modernization, this needs to start becoming part of our system, of our thinking, if we really want to create an opportunity for us to really impact the families that need these services. And I guarantee you, I would imagine after we get a system built where there's more data exchange, we're going to discover a lot of things that maybe we didn't even know before, which is that, we didn't know this data existed in this way and how meaningful it would be. There's a lot that we still need to unpack, but there's enough that we already know to where there's an opportunity there. And I would just say that, obviously some of you I think might be thinking, oh wow, that's not ever been done before, or there's statutory or policy barriers to that. And I would just say, broadly speaking, that I think that we have always said there are. I think that we've made a lot of progress in unpacking what and for what purpose data can be shared and exchanged. And I think that there's sort of a new world and a new analysis we need to do around that. So more to come on that. So right now, I wanted to go on now real fast to what some of the things. This is just a quick snapshot of some of the things that ASTHO is doing in the next few slides. Really quickly, this is our strategic plan and framework for our organization from 2022 to 2024. Our strategic priorities, our core functions and areas that I mentioned earlier, our values, and going into the next slide is where I would kind of dive into our strategic priorities. So, health and racial equity. How do we support states in advancing that? Workforce development, same. Sustainable infrastructure improvements. So we've got workforce and data modernization. What else do agencies need from a performance improvement perspective to improve their functions, to improve the way we engage with our stakeholders, healthcare specifically, that can lead to better outcomes, data modernization, and evidence-based and promising public health practice. And in the next few slides, I want to focus a little bit more on health equity and data modernization. So these two priorities are the ones that are most meaningful. That resonate with me personally the most. But you know, from an advocacy standpoint, we are going to continue to advocate for policies and funding that address health equity over the next 3 years. We want to contribute to evidence, the evidence base that is promoting the most effective intervention strategies for historically marginalized populations. Also implement evidence around sustainable policies that address the root causes of disparities. And then from a workforce perspective, we want to make sure that we're developing all the right resources for state and territorial health agencies to advance diversity, equity, and inclusion initiatives within their jurisdictions. So that's not just within the health department's scope of programs, but that also could be with how do we support healthcare providers with policies that work around health equity. How do we support local governments, local health departments, and local leadership? This is not like a health department only initiative. This is something that everyone can play a role in. And that's something that from both the evidence and the workforce perspective we're looking to do. In the next slide, we'll talk more about data modernization as a strategic priority. We are, of course, as I mentioned before, this is a decade-long effort. We are going to be continuing to advocate for more funding for this to be successful. That $37 billion number from HIMSS and the analysis there is real, and it's a significant amount of funding, but I think it speaks to the amount of time of underfunding and siloed funding we've taken with these systems in the country over the last 40 or 50 years. And so there's a lot that we're going to need to change and migrate to, and that's going to take time and money. We're going to be developing a roadmap that better supports the leadership challenges around this level of change. It's because, again, not just a technology issue, it's a change management and social issue within the workplace, and changing the way that we can potentially operate. Workforce, we've got to make sure the pipeline for enterprise level thinkers like informaticists are there to meet the needs of health departments, so that the health department and health officials are able to better engage the private sector and are ready to engage the private sector when it comes time to new and innovative solutions. And then innovation, hands down, new public-private partnerships, and I'm not talking about contracts or that sort of thing. I'm talking about a new model for engagement with the private sector to learn from each other is important to get off the ground as well. So moving forward, that's going to be something that's really important. I wanted to add real fast for our team, these are the guiding principles that sort of guide our work. We want to build and maintain these strategic P3s that leverage the insights and resources of all. We want to create alignment rather than new siloed initiatives. So that means when public health gets a new grant for something, we don't want to go out into the world and create a new siloed initiative in the community. We want to be able to align where the incentives are there or align like work with all partners going forward. That's where we operate from. And then again, engaging healthcare providers, payers, and community-based organizations in ways that facilitate better outcomes and system efficiency, but without additional burden. That is something that we are really committed to. So a few examples of how we're doing that, and then I'll be wrapping up. So in the next slide, we launched 2 years ago during the pandemic, the ASTHO Public Health Expo, and we realized that part of this was just due to market dynamics, and that Congress invested a lot of money in data modernization, and so naturally, the private sector responds as any good marketplace does. And we were like thinking, well, all of these companies also represent a lot that we can learn from. Not everything, but a lot that we can knowledge. We have knowledge around public health and the challenges we're facing. Let's create a venue where we can share those insights together collectively. And so this here was the group of companies that we worked with on the 2-day event for 2022. We're going to be having another one in 2023, in the spring of 2023. So keep your eye out for that. But this has been really helpful in better understanding and socializing both the challenges of public health, but socializing the insights that the private sector brings that helps us better plan as well. In the next slide, this is one area in particular that I think is really important. Public health is really traditionally focused on lead exposure, asthma control, and service coordination as it relates to housing. But I think as we think about a comprehensive strategy and think about the impact we can have on health equity, to Black adults and Latino adults and other people of color who've experienced equity, and if we harmonized around core strategies and a plan for the complex issues around data modernization, strategic navigation of the complex funding streams we've mentioned, the dual demands, as we've seen in the last 2 years of COVID-19 and existing public health programming, workforce burnout, turnover, and the unprecedented infusion of new and short-term funding. But by working collaboratively, we can overcome a lot of those challenges and get out of the silos of those 3 traditional programs, but think about this more holistically to have a better impact on public health, and that is on health equity. That does not mean that public health needs to do every single one of these functions. It just means that we can help convene around them and lead a more comprehensive solution. And the next slide, I just wanted to provide just a few examples of what members of my team are doing right now around Medicaid and housing. There's traditionally, obviously, a tremendous opportunity for alignment ongoing with the Medicaid programs and public health and health plans around housing, and how Medicaid is leveraging its mechanisms to be strategic about how it's using funding. One thing we've learned is that through that work is that starting small, demonstrating a concept, and starting local is really important, because solutions really do happen there. Relationship building is really important. Strategic level, state level relationships are important. So, identifying the policy, financing, and infrastructure needs of housing counterparts, like the housing, State Department of Housing Commissioner or Secretary, are really important. And as we're doing this again, use it as a way to prioritize the reduction of racial disparities. And in the next slide, it's really, I want to provide a tactical example of some of the work that we do to support our members to ensure that they have all the tools and information they need. So in these examples in New York, they were requesting best practices to incorporating healthy aging or state strategies to address aging and housing, and whatnot, and dashboards. And so what we do is work closely with a variety of partners, including private sector partners and the National Association of Medicaid Directors and others, around doing scans of Medicaid managed care contracts and what language and housing about housing they have, summarizing housing related strategies in a SHIP, which is a state health improvement plan, and give them this information so they have, better insights into what's going on so that we can support long-term alignment. And then in Rhode Island, the same thing. What are state strategies to address housing and health, and to have a menu of strategies to address this, et cetera. So these are, I just want to give a quick, rundown of what we were doing to help advance this. It's certainly not the end all be all. It's not a comprehensive in terms of all the work that needs to be done, but it's a start, and it's where we want to be heading in terms of shaping and supporting our members going forward. So to wrap up real fast, and then in slide 42, I wanted to just provide some final thoughts on what we do kind of going forward for continued alignment, impact, and planning and socializing of this work. Nurturing innovation. We need to continue to leverage multi-sector public-private partnerships. We want to nurture innovation from a data modernization and health equity perspective. We want to innovate both in the cloud and in communities, right? And then for prioritizing standards, we need to maintain efforts to develop common data measures, standards, and definitions, as well as a process to certify public health systems long-term. We're going to need resources and time for that, but projects like the TEFCA, Helios, the North Star architecture that ONC and CDC are working on together are really critical to the success of this. The Gravity Project, as it relates to establishing standards for social determinants, data capture nationwide, all of this is very critical and important, and we must continue to pay attention to this, to inform it, be at the table, and work and to better understand what the concerns of the whole range of stakeholders are, so that we make sure that we are getting exactly what we need from this going forward. And then drive equity through the design. We need to employ human-centered design principles in systems and solution development, and design with health equity as the outcome. And so that's going to mean that we need to add activities around, mapping what data is needed. What's the next generation of measures of health equity that we need to consider? All of these things we need to be designing around end users and the people who are going to benefit from this work. We are going to continue to grow the workforce pipeline. We have severe workforce issues in public health, both related to our pipeline and the competitiveness, frankly, of government to retain this new generation of leaders. And so I think that it will likely include partnership with the private sector in new ways that we haven't yet done. And we're looking forward to working with everyone, figuring that out. And then finally, we have to sustain these investments. We've already talked about, and I don't want to set, I don't want to, we've all read enough that public health's been underfunded, and it has. These efforts are significant and big, and I think that if we want to emerge from this stronger in a year and in 10 years, we have got to continue to make the investments in initiatives like this in an ongoing way that's sustainable, rethinking how we provide incentives to health plans, to providers, to be more engaged in reporting. All of this is essential. We've got to be thinking outside the box, and it can't just be stick approaches. It's got to be carrots as well, and we've got to talk about that and be clear about it. So We really look forward to working with all of you and many others on this conversation as we move forward collectively. Thank you, Denny, and to your whole team at the Massachusetts Health Data Consortium, and for allowing ASTHO to be here. And I'll send it back to you.
Well, JT, that was terrific. We have a lot of questions, and we have about 15 minutes. So we're going to move through these questions, starting with the ones that are sort of risen to the top based on the assessment of my colleague Janice Karen, who was looking at all the questions that are coming across the transom. One of the things that we're seeing in the industry, for lack of a better phrase, is that health information technology is getting smaller. And by smaller, what I mean is there is an increasing emphasis on data, standardization of data. There is an increasing emphasis on low-cost application programming interfaces that conform to the standard we know as FHIR, Fast Healthcare Interoperability Resources.
Yep.
And the question I have of you in that respect is, are you seeing FHIR adoption in public health? Are you seeing the work that is being done by the accelerators? You know, you mentioned one, a public health data accelerator, but there's work being done to make your work a little less difficult, and you have a big job in front of you. Are you looking at FHIR and the US CDI and the work that's
absolutely,
coming
yeah, all of that, when I was listing out Helios, TEFCA, and certification, yes, all those are part of that list as well. We actually, so state vital records programs, I know of at least 9 states that have received funding and support to pilot and test FHIR as it relates to birth and death data systems and reporting. And then there are ASTHO, along with one of our partners, CSTE, the Council for State and Territorial Epidemiologists, are also going to be working on test cases, other test cases for FHIR with states. That project is not quite off the ground yet, but it will be. But I mean, absolutely 100%. All of that, all of those components are part of success long term. But we're very involved. Myself and another of my colleagues, Jamie Pina, who serves as our Vice President for Public Health Data Modernization at ASTHO, are very involved in the Data Modernization Consortium with a variety of other organizations, and including HIMSS and others, in helping shape the direction we're going. So it is a lot. I mean, we're still sort of responding to COVID and now monkeypox, so we're keeping up with those things too. But to the extent that all of these different initiatives and components of modernization success are being developed, we're at the table for sure and tracking that.
Thank you. You know, when it comes to implementing standards, whether it's in the data themselves or in the way in which the data are actually made interoperable, there are a lot of challenges. We see it in the private sector. In Massachusetts, we have universal, health insurance coverage for all intents and purposes, and we still see struggles between public and private organizations around, the barriers that go into moving to a standards-based, low-code, decentralized way of sharing information. What are some of the biggest challenges that you see from your unique vantage point? You have a tremendously diverse constituency, and looking across that, each one has a different idea of what constitutes success. As you pointed out, the money gets doled out by different categories. People have their own particular views of this and what constitutes success. How do you balance that? And how do you address what are bound to be enormous challenges in that?
Yeah, that is a really good question, and I think that is probably the biggest challenge and barrier for us to address. So a few things, because this came up recently in the public health certification, system certification conversation, and also data authorities. we've got this, core set of data that the CDC needs from every jurisdiction, right, during the national response. And then there's a whole set of additional data that state and locals need for their own analysis or public health action and next steps, because that's where public health, frankly, is deployed, is at the state and local level. And so we're going to have to decide, and this goes back to my comment about flexibility, do we need flexibility the way we've been accustomed to it prior, or do we need flexibility in new areas that we just haven't conceived of yet? And that's the kind of conversations I think we have that gets us through those challenges. I do think we need to move to a world where systems are certified. I think that every day I hear from someone about some challenge about how we don't define certain data elements the same and how much of a challenge that is. And so I think that I think we can get there. I think we can overcome that. I think that what the challenge is right now in this moment is that we do not have the time and bandwidth to possibly try to tackle all that at once. And so I think, though, that my definition of success coming out of this, though, is that we would get there, and we're going to have to take the time and prioritize what must come first. And so I think patience, a little bit of patience. It took us a long time to get in the way we are now, right? And so it's going to take a little time to standardize what needs to be standardized, and then understand what truly needs to be unique at a local or state level too. So
thank you. Not a small job. It's no mean feat. Do you see, we talk a lot about, the nuts and bolts of data standards, the nuts and bolts of interoperability, getting systems to communicate with each other through these application programming interfaces that are also built on a set of standards. But we also have new technologies that are coming around the transom. Everybody wants to find an application for them. And I'm thinking of, artificial intelligence and its components, machine learning, natural language processing, probabilistic problem solving, et cetera. Are you looking at or thinking about ways, and I'm not thinking like in the future, I'm thinking about, given the kind of burdens that you have across so many jurisdictions, are there ways in which some of these advanced technologies can help you when it comes to collecting data, or are you taking a more wait and see approach when it comes to their use?
Yeah, I think it's sort of like in our parking lot right now. I think everyone, like the community, largely sees the benefit of it. I think that it's something that's that's got to come, I think, a little bit after, because I think especially when it comes to AI or machine learning, it's then the intersection of that with what does that mean for how does that change the practice of epidemiology, and that sort of thing. There's some things that we are working on that are a little bit more experimental. I don't think we're going to get to a point where we're going to be to the scale that you might be thinking of as you were asking the question. I think that we've got to stabilize and ensure a more timely response. We've got to streamline reporting of data and automate it to where it's real time between the Fed, state, and locals, and solve that problem first, and then start to pivot towards more advanced methods. Because I also think that I don't think I would think that there's enough understanding of the benefits of those yet too, that we've got to again address. And that's something I'd look to address. Like when we say public-private partnerships, that's a perfect example of of how can we partner together to create understanding of the benefits and what would be needed to sort of deploy that within the public sector, and who would we partner with to help make that happen. to increase understanding, I think is something that, would be one way we might want to, exercise a P3 concept. But it's definitely on our radar. I don't think it's necessarily, I don't know that they can solve the issues we're really under the gun for right now fast enough, when we just have to clearly solve a few problems first and then sort of level set. I think like anything like this that's going to evolve, we're going to get to a point where we've made enough progress in one area. We're still advocating for additional resources, and I think that's the other outlier, is what additional resources is Congress going to have the appetite for, which is impacted by, the 2022 election, midterms, right? All this stuff, all of that comes into play in terms of what we're able to get done next. But it's definitely it's on our radar, and we're open, when we're ready to have the combo.
That makes good sense. We have time for one more question with a little less than 5 minutes to go today. And let me bring that question up. If you could wave a magic wand and have 3, 4, 5 pieces of data available that were in an absolutely standard format for every person living in the US, inclusive of the people and the organizations and the municipalities that are part of what you at ASTHO do, what would those 3 to 5 pieces of data be? Just as a thought experiment. What are some of the things that you would say? Life would be wonderful if we could get these 3 or 5 pieces of information.
Yeah, in aggregate, I mean, within the context of this presentation, from a health equity lens, I think it's race and ethnicity, age, census tracts, since we could get, rurality and urbanity.
Those are great ones. And I have to say, I think
we could overlay that with transportation. Yeah, like I think there's other data sets out there too where we might overlay that from a social determinants perspective to picking one that would be effective. And I think that how we leverage either, I think looking at housing or data from housing programs, or like housing security data at the census tract level as well from SNAP would be one. It's just one indicator, obviously, but it would be an interesting analysis to help us be more targeted at where we see, the most ingrained, in-depth disparities that we can, collectively get to as a country. Because at the end of the day, this is about scalability and knowns. So, we know there's, I want to be clear, I think we know that at local levels, there's a lot of innovation going on. What we're trying to do as a national organization is figure out what is actionable and scalable that we can collectively get behind as a country. So, but those would be some of the data elements I'd be interested in for sure. Yeah.
Well, it makes sense. You need to know who people are and where they're at before you can figure out whether or not what states and municipalities are doing or need to do are actually going to make a difference. So that makes a lot of sense. This, ladies and gentlemen, this concludes our program today. I want to thank JTU for joining us. I want to thank ASTHO and the work that you do and for what you shared with us about the organization and its mission. And I want to make sure I thank everyone in the audience for taking time out of your busy days to participate in today's webinar. With that in mind, we know how busy you are, but we would appreciate it if you took a brief moment to fill out a very brief survey that we will be showing you shortly, so that we can organize, design, and present our webinars in a way that best meets your needs. So thank you all for joining us. And with that, we will let you complete the survey. And thank you for joining our discussion. We're adjourned.